can I start with welcoming our observers as governors. We've definitely got Art, we've got Simon, I think I saw Shad popping up. I'm expecting Shad, can't see whether he's on the list. Yeah. And the final one is Cecilia, who we're just admitting as we speak. So we obviously, this is a public meeting. It will be being broadcast and available to people. So in that sense, anybody can see this, but we think it's helpful for a group of the governors who would usually be present in the audience to have a chance to be on the call, seeing how the dynamics of it operate. And so it's Cecilia, Art, Chad and Simon with us today. I'd like to also talk a little bit about our approach to governance and meetings in these very challenging times. We have been working to make sure that we defer business that can sensibly be deferred while the trust is under the pressure that we're under. So working with Neil and with Eileen and obviously support from other colleagues, we've been doing our best to try and put agenda items that don't need to be taken in this meeting and the next ones forward to a time when the pressure is a little less great. And we're also aiming to try and avoid doing things more than once. This was a day in which we would have been aiming to have face-to-face meetings with the board having a chance to meet with the Council of Governors towards the end of the day. We're aiming to maintain those connections by having virtual coffees this afternoon between the non-executive directors and governors. But we've not included executive directors on that in order to free them for the work that they're doing, particularly around the COVID response. We're also taking to the Council of Governors this evening a presentation on staff wellbeing, which in other circumstances we probably would have received something on that as part of our agenda today, but we don't want to do it twice. So we're going to do that with the Council of Governors later. And it may well be that individual executive directors get called away to check things during the course of the morning. And if that happens, we will simply note that that's been necessary. And the first of examples of that is that we won't have Sam Foster joining us until probably about 10 o'clock when she gets off a Southeast Regional call. So with your agreement, which for these purposes I'm going to assume, we're shifting around the agenda to make sure we can take it when Sam joins us. So that, for example, means that we'll take the patient story later in the agenda than we usually do. So that's really just an illustration of the strange times in which we are working. And I'd like to start by saying how proud I am to be associated with the Trust at this stage. So since we've last met, we've seen some of the best things about working in Oxford. So we've seen the benefits of the clinical and research collaborations, the launching of the Oxford AstraZeneca vaccine, and more members of this meeting have been on TV, I think, since last time than usual. Indeed, the New Yorker has even covered the activities of our executive team since we last met. So that is, it's a fantastic privilege to be part of that. We also have, as always, amazing responses from our frontline staff. And we'll hear a little bit later on, I'm sure, about quite how pressurised the hospitals are at the moment. We've seen that regularly through the last few weeks, and I'm immensely impressed by the dedication of all those people on this call in the front line in dealing with that. And it is as challenging a time in the NHS as I imagine any of us have remembered. And we should be really proud of the work that our staff are doing. So I want to start by thanking them all, including those on this call, for that. We'll hear a bit more about all of those things later, but I'm encouraging everybody to be as efficient and focused as we can, because the more time we allow our executives to deal with their frontline work, the easier these meetings get as we go through. So thank you very much, everybody, for what you have been doing. And I think we'll then move to the more formal parts of the business. The first of which is to check declarations of interests, and I'm sure Anne will be noting her interest as a trustee of the hospital charity. Anne, is there anything else we need to note apart from that?
No, I don't think so. No, thank you.
Thank you very much, Anne. Are there any other declarations of interest that we need to note in relation to particularly items on the agenda? Others will make their way through into the declaration. Thank you very much. We then need to amend and confirm as necessary the minutes of the meeting that we held in November. I'm not aware of any corrections to Neil's minutes. Are there any coming in today? No, thank you very much. Well done, Neil. So we therefore approve those minutes. If I turn to the action log, there are 3 items on the action log, 2 which we are clear that I think we should be able to close. So the first related to the impact of pay controls. We discussed that at the Integrated Assurance Committee in December, and the IAC is content that that will be closed as an action at this stage. And on that basis, I think it would be appropriate to ask the board to close that action here as well, which is of course not to say that it may not come back as a new action in due course if we are concerned about things happening, but I think it's closed for our scrutiny now. And similarly, the long wait patients. I imagine we'll come back to that in due course, but the particular thing that was an action in terms of understanding the surveillance reporting at the ICS level, again, we took at the December meeting of IAC, and the proposal is that we close it as an action item, and I'm pleased to see Sarah nodding at that. And that leaves one other item on the action log, which just need to check whether we have any chance of closing at this stage. And David, I think you might be able to speak to that one. So I'm scrolling down to get to the bit where it's formulated. So this was the backlog figures on service desk calls. David, are you with us?
I am. Sorry, I'm just seeing with my headset. But so morning. Yes, we've updated the data to show the difference, and it's probably worth picking that up when we get to the IPR element, Chair, because it's a difficult thing to demonstrate given what the priority levels mean. But we have updated it, and it's probably worth a discussion at that point for further refinement.
So should we come back when we've had the IPR discussion and decide whether to close this, or are you saying that you think we can close the action in that the figures are included, but we then need to discuss as part of the IPR what the implications are?
Yes, please.
So we close the action at this point and do it as part of our regular IPR reporting. Have I understood right, David?
That's correct. I think that's
fine.
I think that's the best way of doing it, Jonathan.
It's okay. Thank you, Neil. So we will close that action log item without prejudice to whether anybody wants to reopen one when we get to looking at the IPR, if anything comes up that requires specific actions at that stage. Thank you very much. In relation to Chair's business today, I will be taking to the Council of Governors this evening in its confidential stage the recommendation of 2 new non-executive director appointments. Because it needs to be approved or not by the Council of Governors at that stage, I obviously can't make any announcement at this stage. I have, though, I think the ability to say we think we have 2 strong recommendations to make. We have gone out looking for non-executive directors who would provide us additional competence around the non-exec side of the table in relation to clinical expertise, but not from the medical profession. And secondly, in relation to system working. We were also very keen to enhance the diversity of voices and experience around the table. I think when you see the recommendations, you will be recognise that we've achieved those things. We had a strong field, and thanks to Odgers Bernstein for supporting us in that. And there was a fairly robust grilling process in terms of interviews and discussions from the members of the Governor's RNAC committee. So we will be able to say more than that fairly shortly, but because of the process and the confidentiality, I can't say more at this stage. But those members of the public looking at this should very quickly see the outcome of that after the Council of Governors meeting this evening. I don't think I have any other chair's business, and I'll therefore hand over to Bruno to pick up anything he particularly wants to note from or add to the Chief Executive's report that was circulated. Bruno.
Thanks, Jonathan. And I mean, the report, I assume everybody was able to read. I'm going to probably give more up-to-date information as things are evolving very quickly in the Trust. The COVID-19 infection rates are going up significantly, also in our region. And today, the Trust has almost 300 COVID-19 patients in the Trust, which is more than double the peak of the first wave. The peak of the first wave, we had about 140 patients in the Trust at the peak. So our peak in the second wave is already double the number of patients than we had in the first wave, and we're not at the peak yet. So it's still going up. So we're extremely focused on making sure that we have sufficient capacity to admit patients that need to be admitted, to receive oxygen. And we have sort of level 1, level 2, level 3 types of care, and we need to make sure that we have capacity for all of those patients. On the more positive side, thanks to some of the advances.
Bruno, I wonder, given that this is a public meeting, I wonder if a quick explanation of level 1, 2 and 3 care would be helpful for those watching.
Yeah, it's different levels of oxygen that is given to the patients. Level 3 is actually in critical care, and patients are being intubated and mechanically ventilated. So that's level 3. And the good news is that because of the advances in therapy, we see that less patients need to be admitted to level 3 than in the first wave. It's about half of it. So in the first wave, we admitted about 10% of the patients in the hospital to the level 3 care units. And in the second wave, it's less than 5%. So it's double the number of patients, but half of the percentage that needs to be admitted to level 3. Level 2 is non-invasive ventilation, and level 1 is oxygen supply, but not with normal oxygen flow. So those are the levels. Clearly, this has an impact on other patient care. We've cancelled the routine electives as we did in the first wave, again in the second wave. And we're having to redeploy quite a lot of staff to be able to take care of these rising number of COVID-19 patients. And we also have increasing absence of staff because they're taken out by the infection, or they have to self-isolate because of a high-risk contact. So we're in a very difficult place, Jonathan, and my biggest concern is to have sufficient capacity, but also to make sure that we make this feasible for staff, because it's extremely pressured, and it's relentless, because we've had maybe a bit of breathing space over the summer of last year. But after the summer, we basically had already the first signs of the second wave, and it's the staff well-being is probably the biggest concern that we have. On the more positive side, if I can share some hope going forward, you already mentioned the Pfizer and the Oxford vaccinations that have started. We have vaccinated almost 6,000 our members, and that's increasing every day. And clearly, vaccinations will help us to protect staff members, but also the patients at risk for a hospitalization. So once the mass vaccination campaign gets rolled out, we will see an impact on the admissions and also on the staff absence. But we're still a few weeks away from that point. So we're trying to really be responsive to support staff in these difficult days and weeks. The extra leave day, which the board approved before Christmas, was very well received. It's also mentioned in the chief executive update. We should also acknowledge some of the great work that we're doing. Even the Queen has noticed and given some awards to staff, but we also need to constantly appreciate what people are doing and the amazing stuff that's being realized. And I think the Chief Executive Report is full of some of those achievements. Just to pick one that isn't listed in it, but as we have more COVID-19 patients, we also are able to recruit more patients into the clinical trials for the COVID-19 response. And we're doing extremely well nationally in terms of recruitment into those trials. A very important one is the recovery trial, which we have been using to identify which treatments work or don't work. And that led to the use of cortisone, which we talked about last year. It also led to the use of the interleukin-6 antibodies, again, which now have been approved. And I'm proud to say that 1 out of 5 patients admitted into the trust with COVID-19 are enrolled into the recovery trial, which is double the target of the National Institute of Health Research. So despite all of the pressures and the very difficult time that we all have, whether we're residents, patients, or staff in the trust, it's difficult for all of us. I'm very proud that we're able to take care in an excellent way of the COVID-19 patients and be able to contribute to a response which hopefully will avoid us to have a third wave, assuming that we can come out of lockdown with a mass vaccination that will have vaccinated 15 million people in the UK.
Thank you, Bruno. Are there any? Katie's raised hands. Katie.
Thank you, Jonathan. Bruno, I just wanted to make the observation that throughout this dreadful period of worry, your staff have been exemplary and not just in obviously their care of patients, but their responsiveness to NEDs as well. I mean, I've tried very, very, very hard not to get involved and not to sort of get in the way and this sort of thing, but on the 1 or 2 occasions where I've needed a response or asked a question, the response has been fantastic. And not only that I've been noticing, unfortunately, the time between the last email sent at night or the last WhatsApp or the last sort of time that somebody was active to the time that they were active again in the morning is very, very short. And I just wanted to compliment you and your team on that, but also just sound a note of warning that they are working very, very, very hard. And I just wanted to note that.
No, thank you. And it is, I expressed a concern about the well-being of all staff members, but it's also a concern personally about my own executive team. These are very stressful and difficult times, and we're all working very long hours. So I just want to use this opportunity to thank the executive team for the great support.
Thank you both, Katie and Bruno. And of course, I completely reiterate that it is our responsibility as a board to keep track on our own resilience. And Ned raised that, as you know, at the briefing last week, and Eileen and I have been sort of working on how we take stock of the business continuity challenges and what we can do for resilience of the board. Bruno has been very firm with his executive colleagues on taking leave when they can, but it is when they can, and I'm very grateful to a number of them coming off leave in a very careful way to do things that have to be done, but still protecting a bit of space so that they preserve energy, because we have quite a long way to go on this challenge. And I think that's a well observed point. Thank you, Katie. Claire.
Thank you, Jonathan. I'd just like to support and echo what Katie said, and to say that I feel very proud to be a part of this organisation. I just wanted to touch on sort of mental health. I think we're doing a lot, and I know we're going to hear a bit more in the governors' meeting about support to staff. But it occurs to me that as we come out of this wave and things start to calm down a bit, might be the point where, you know, people have managed to keep going because of the crisis and then start to feel really overwhelmed. And I just wondered whether we are sort of thinking about whether that might happen and sort of what support we're putting in place then. I also think, you know, some people might reconsider whether they want a career in medicine or in nursing and so on as a result of some of their experiences. So it's really important that we give the support at the right time.
Thank you very much, Claire. I was going to invite Terry to comment on that, but he's already put his hand up. So, Terry.
Thanks, Jonathan. Yes, Claire, we have started to think about that, and you'll hear a lot more detail about that later on today. But we've been working really closely with SiteMed in terms of putting in our resources for potential PTSD. We've increased numbers of SiteMed staff that we're going to have, because we've anticipated this. In fact, we thought it will be 6 months after the first peak, but that hasn't occurred yet, but we're preparing for it. We've got the staffing in place to deal with it, and our overall strategy, which you will hear about later, puts us in a fairly good place. But we still think that there is more to do to make sure that we focus on our staff around mental health and well-being.
I think probably, Claire and Terry, that if it doesn't come a formal standing agenda item, I mean, it will be on our agenda each time we're getting a briefing and each time we are reviewing our progress, because fundamentally we're aiming to focus on the priorities for our patients that really make a difference to their care, and we can't deliver that if our people are not looked after, because the delivery of that care is partly about supplies of things like oxygen, but it's mainly about the quality of the people and the resilience of the people. So I think each meeting we will be coming back to those sorts of questions, and we'll have a bit of a framework to do that from the presentation from the Council of Governors this evening, which will give us an overview of the work that's going on. So I suppose I'm sort of incorporating that into our board meeting, though that the fact that it's not on the agenda today is not because it's not a key focus of the board's activities. It's because it felt the best place to take it is in the Council of Governors this evening. So we'll pick that up. Thank you very much, Claire, and to Terry. Anything else from Bruno's report? Thank you. We will take the patient perspective, which is also the point at which I think we get our best discussion of the vaccination questions when Sam is able to join us. Bruno, you had given us some update on the COVID context as part of that report. Is there anything else you want to pick up under item 7 on the update on the response and recovery that you haven't already noted?
I included that into my chief executive update, Jonathan.
So just want to check whether there are any other questions people had held in case there was a separate issue on the COVID response. Okay, thank you. That takes us then to the integrated performance report. May I say that during the course of the non-executive director interviews, there were a number of applicants who complimented the quality of the integrated performance report. So perhaps we can pass back that how much we find this useful, particularly the summary work early on. So those who've put a lot of effort into this, perhaps we can give them the credit for that being noticed from outside. As we've taken the last few meetings, we've not invited the chief officers to present. We'll go straight into questions that people want to explore further or observations people want to make. And first off the mark today is Anne. Anne.
Okay, thank you very much. So this was something that was prompted by reading the minutes, actually. We talked last time about introducing the new system with NHS 111. And clearly, you know, the situation at the moment is extremely stretched, but I just wondered how that was going and whether that has had the opportunity of getting going such that people do contact 111 before they come to A&E. So maybe that's a question for Sarah.
Sarah, can you answer it?
Yes, sorry, I was just, yes, thank you, Anne. So yes, 111 is progressing well and working very closely, obviously, with our emergency departments. There's a virtual head injury pathway that's already in place. There's been significant working with GP direct access to specialties. So in trying to reduce the impact on our emergency departments, so for example, to our specialties such as gynecology, to our surgical specialties. So that's been really helpful, trying to reduce the capacity. Also looking at the, other areas such as urology and ophthalmology, so out of hours, which is really helpful. We have seen a significant breach reduction through using the 111 service, and particularly access to our paediatric service, so the clinical decision unit in children's services. So I think we can see an actual reduction in number of attendances as well, and overall, which is really satisfying. So it's just ongoing monitoring of that at work. Obviously, still early stages, but there's a lot of work that's been going into it, and working with colleagues across, not only within the trust, but of course across the system.
So can I just follow up and say, do we have any sense yet about what proportion of our people are actually using that service who are coming into the emergency department?
I haven't got those numbers with me, to be fair, Anne, but I can get those and I'll share with those after the meeting, if that's okay.
Thank you. Because obviously there's an issue about there's so many messages at the moment going out to
Sure.
public that you know, a number of people may not have picked up on that. So the question would be, you know, whether we need to do any more to make that public, which obviously it's having a beneficial effect. So that's something to consider.
Yeah, I mean, we've advertised it well, and working with system partners, particularly SCAS, but absolutely I'll get those numbers of how many have come and booked in.
Thank you.
Thank you very much. So I now have quite a long queue. Next will be Katie, Sarah after Katie, and Paula after that. And I still have a longer queue than that, but I'll only do 3 at a time just so people know the order. So Katie next.
Thank you, Jonathan. So if I can just invite, excuse me, David to comment again then. So he talked about the fact that we had an action closed from the log around the backlog in the service desk. And I'm happy that we closed that item, because I know that there's some tools, things that we need to do, and we'll come back to the board about that, I think, another time. But I want to just look at the IPR piece for data, and I'm raise a couple of points. Firstly, I want to invite David to just pick up on a slight anomaly. If you're looking at the graphs, and it's on page 76 of the IPR or page 111 of the pack, there is a graph at the bottom of that page which suggests that audit recommendations stopped being actioned in August, and that isn't the case. That is just a data anomaly, and in fact we are tracking it according to plan on that. So I just want to ask David just to remark on that, but also David, if you could just make a remark about HIMSS as well, because that is still ongoing work. I'm still very proud of what you're doing. There is obviously some work that needs to be done that can't be done during COVID, but I'd just like to invite David to comment on those 2 things, please.
And David, as you do so, for the public, remind us what HIMSS is.
Okay, so that'll be a test and remember my acronyms. So the first of all, with the graph, yes, this is for assurance, it's because we've actually tracked exactly our projection. It's an Excel anomaly that they overlay each other, so it says sort of inappropriate graph. So apologies, I should have spotted that it could be presented better. But moving forwards, we're waiting for the follow-up audit cycles through the annual plan anyway in this quarter, so we'll update this to reflect any findings that we have from our follow-up audits to make sure they are closed, and I'll make sure it's presented clearer moving forwards. With regards to HIMSS, this is the It's an independent accreditation.
It's the Healthcare Information and Management Systems Society, because I found the page which explains the acronym, David.
Well done, Chair, because I couldn't remember the society. So this is a level of digital maturity that they award internationally. It goes up to level 7. As a GDE awarded trust in 2016, the obligation or ambition from the GDE programme was to generate 16
Global Digital Exemplar, for those who don't remember that far back.
Sorry, yes. Thank you. It's the curse of the acronyms, apologies. So the Global Digital Exemplar programme set an ambition to have 16 level 7 HIMSS hospitals in the UK. At that point, there were none. And at that point, there were only 2 level 6. Of the 2 that were level 6 in 2016, 1 has had their accreditation removed and 1 isn't going for re-accreditation. From the GDE programme, there is now 2 HIMSS level 7, which is the highest level, and 6 level 6s. And I'm very proud to say that we've achieved the level 6 at the NOC. The difference between level 6 and level 7 is essentially the pervasiveness of said technology. So this is around the closed loop meds administration. For example, for level 6, it has to be X%. For level 7, it has to be 90%. So it's a sort of step up, but the underlying investment in the technology is the same. So we're really proud to achieve the 6, and to also achieve the 6 during a pandemic. Which is, again, credit to both our clinical and non-clinical staff and our commitment to delivering safe patient care underpinned by effective digital. And just to moving forwards, we've still got the ambition to achieve level 6 across the rest of our enterprise, and then we'll go for our level 7. At the moment, I've just asked for the project to consider how we do that. So I've put the project into an amber level because obviously we can't work at the pace necessary we'd like to with clinical areas at the moment as we work through the COVID response, and then we'll re-baseline that project moving forwards. But our strategic ambition is still to achieve level 7.
Thank you very much, David. Sarah is next, Sarah Horton.
Thank you, Chair. I just wanted to follow up on your comments about the quality of the pack, and I was very excited, having just been on a training course to learn about statistical process control charts, to see them in our HR section. I think, Terry, huge congratulations. I think the clarity that it brings to the data and the allowing us to focus on what really matters is key. So I see that it stands out really clearly, the progress you're making in lots of areas in HR. And it also brings out really clearly the odd wobble around COVID. So I think congratulations on that. And are we going to see this rolled out across the pack more widely? Because I think it would really help us focus on what is statistically relevant, as opposed to the odd movements that we see that may not be statistically relevant.
So is that a question for Terry, or is that a question?
Well, I think there's a question. There's a congratulations to Terry, and I don't know whether he would like to comment on it, on what it shows us, and a more general question to whoever's in charge of developing the pack about where this goes next.
So thank you very much. It's the team really who I need to thank for putting it in place. After we've had some discussion about what is statistically relevant, we have had a discussion as an exec about ongoing development, and we've also had discussions with Mark Curry about how we can one, make it more of an integrated report and get more consistency throughout. It is a work in progress, though. It's something that we're looking to do, but it's one of the things that's taken a little bit of a back step because of all of the other stuff that we need to focus on.
And I think that's wholly understandable at this stage. And I think Sarah's confirming our support for that direction of travel. The pace question, is one of the many things that we're dealing with at the moment. So I think the answer, Sarah, is we are moving in that direction across the pack. Again, very grateful, particularly to those who are not on the call, but who need to know that this is noticed. Perhaps our executive colleagues will make sure that that is passed back, especially to Mark. Sarah, is that the final point you had today? Yep. So next I have Paula, and after Paula it will be Claire, followed by Tony. Paula.
Thank you. Yeah, again, complementary piece, just to reiterate that, because the pack is getting so much more useful, it's really clear around the A&E performance, some of the issues that we were working on, and the cancer standards, the issues that we've got there. I guess my reflection as I was reading this is that this is all as at November data. We are now sitting in quite a different place. So rather than critiquing this, which felt a bit unhelpful, I wonder if maybe Sarah could just give us, without, I'm not asking for the full specifics, etc., but a bit of a flavour of how this has changed now that we are sitting a bit further on, and to what extent we're managing to hold in relation to our performance standards or not.
And I wonder, Sarah, when you do that, it would also be helpful to give a bit of an indication of what we should expect going forward, because I think a number of these performance indicators might well look a bit different next time we see them because of the impact of it. So I think it's an opportunity to bring us up to date a bit on where we are now, but also help us understand what we should be thinking about when next time we see these figures as well. Sarah.
Thank you. So I'll cover across perhaps some of the performance targets, and please pick me up if I've missed on something that you wanted more information on. So if we particularly start with the emergency pathway, so although we had in month 8 a good performance and improving performance, we have seen a gradual deterioration in December of our performance, and really regularly dropping below 80% for the 4-hour standard. And actually, you can see that quite right across the Bob ICS, our integrated care system, but also much more widely across the Southeast regional. And we see that daily. So certainly our performance has dropped and has got worse, particularly since the 28th of December. And that's really been particularly about our response, our COVID response, and the changes to the numbers at the front door. And we can see, certainly I've got the information for December here, we can see the number of 4-hour breaches have gone up by 596 for the end of December, and between 4 and 12-hour trolley waits have also gone up by 358. And indeed, unfortunately, we had one 12-hour trolley wait in December. We have had none since that one patient in December, but we are under significant pressure in both of our emergency departments. We've had to look at our flow, particularly through the emergency department, and the acuity of patients coming in has changed. Despite the work that we've been doing with 111, certainly the patients have come in with a lot more with COVID, and particularly making sure that we place our patients in the right beds, particularly looking at the COVID beds, non-COVID beds, our respiratory pathway, and our ventilated pathway, as Bruno talked about earlier on. And that's some of the areas that we are really concentrating on in our emergency department. We have now looked at our emergency assessment unit at the John Radcliffe, has now become a level 2 area, a respiratory pathway area, and we've moved our emergency assessment units to level 5 to ensure that flow becomes better for moving upstairs. So that's the changes that we've made, and we did make similar changes, if you recall, in wave 1. In terms of, if I just move on to our the elective pathway, we have seen some more cancellations coming at the end of December, January, where we have, as Bruno said, paused our routine elective work for those patients that are waiting over 3 months and beyond. So we're only looking at patients who have emergency or clinically urgent patients to be treated, and that includes our cancer patients, both within our outpatient departments and also within our inpatients and day cases, and that's on all sites. And that's primarily to make sure that we can deploy staff from the sites to support our COVID response, which is mainly on the JR site and the Horton sites. We have had to move some services to allow for greater medical and COVID response in the JR2 building itself. So trauma services and vascular services have moved to the West Wing. We've also amalgamated wards on the Nuffield Orthopaedic Centre site and the Churchill site to ensure that we can redeploy staff to support our teams in our critical care areas to support those ventilated and respiratory pathways. So at the Hawthorne, we are also opened up additional capacity within our CCU area. We're also looking at and working closely with the independent sector. So we're working just with colleagues about what they can offer and help us over the coming weeks, what in our response to the support, making sure that we can maintain those key pathways, particularly with cancer and urgent care work. So if I just briefly stop there, and people can perhaps ask me a question. Any questions?
Thank you very much. Paula, you initiated that. Do you want to come back on, Sarah? You're on mute, Paula.
Sorry, I get the prize for the first one on that today. No, actually, that's really helpful. That's the kind of update I was after. I guess that's not surprising from what we know and the planning that we know you've done. It does put it into sharp relief, really, against these figures that we've got in front of us.
And I think what I didn't mention, clearly we can see a reduction in our 52 weeks, our longer waiters. And so we have stopped, as I said earlier on, those treating those patients at this moment unless they become clinically urgent. So there is a pause at the moment. So we will see an increase in 52-week wait patients going forward. So so we will expect that, but obviously we're also looking at right now what recovery looks like. So we haven't stopped that focus, but clearly our absolute focus is supporting our staff and our patients in that COVID response.
Yeah,
thanks. I think when we come back to this, we'll need to think a little bit about how we get the board a good understanding of the context. And I'm thinking of a few things here. One is, we remain in the National Incident Command and Control mode. So many of these things are choices that are not taken just by our executive team. They're taken within a top-down system, looking at the balance between what's right in Oxford, what's right in the region, and what's right across the country. And that may mean that there are some pressures on the performance that we just need to understand when we see it. And that would include some things that come into us that are not our usual catchments, as well as seeking to have patients who we might usually bring here looked after elsewhere in order to create capacity here. Sarah, do you want to comment on that?
Sorry, I was just what I forgot to mention is that actually the outstanding work that we've been working so closely with our system partners to support our those patients who are perhaps with delayed. So there is exceptional working with partners within the County Council, social services, with the Oxford Health, our SCAS colleagues and voluntary sector, particularly around Oxfordshire, to help us support those patients moving to the most appropriate destination outside of hospital. So that's been really outstanding, and they've reduced those number of delays and reduced the number of patients waiting over 21 days, that's really helped our flow. And we've also been working very closely with our BOB colleagues right across the BOB integrated care system, particularly across the mutual aid around critical care and wider across the southeast region. That's why Sam's not on the call as yet. So just working at that mutual aid and supporting colleagues, which has been really good.
Thank you. So I think we might need to think about a little narrative context, because obviously that means that our individual metrics need to be understood as playing a part in a broader situation. So I think that as we take stock of the particular figures over December and January, that's probably going to be very important for the board to understand as it makes sense of it.
Thank you.
Thank you. Claire, you were next, and I have Tony after Claire.
Thanks, Jonathan. I just had a couple of specific questions on the report, if I may. The first one was on C. difficile, and I sort of wondered how concerning the numbers are, first of all. And secondly, when I looked at, I think it's page 37 of the report, where you get a bit more detail, it was in green, despite the fact that we appear to be over the threshold. And I just thought that was a little bit misleading. And then I have another question. Should I ask that now, or would you like to answer the
Let's
first
take
one?
that one first. That will be
Thanks,
for
Jonathan.
Megan, will it?
Yes, it will. Thank you, Claire. I was trying to find page 37, which I haven't been able to, but
It's 72 on the main pack or 37 on the slide set, I think. Is that the right one, Claire?
Yeah, that's right.
It's the key quality metrics table.
if I could just talk about C. diff. So normally every year the Oxfordshire CCG sets us a cumulative target for C. diff cases, which they didn't this year. So we are measuring our performance against last year's target. And of course we want to remain below that, it was 89, and last year we came in below 89. The definitions of how C. diff is monitored changed partway through last year. We now look at not only hospital associated infections, we also look at those patients who get C. diff or are diagnosed with C. diff when they're in the community but have been recently discharged. And those have been more difficult to manage towards the end of last year. Interestingly, in October and November, we did go above last year's cumulative target for the month. And we put in a number of measures in areas where we've found any hotspots. But in December, there were no hospital-associated infections. So we're just trying to work out whether this is related to the antimicrobial resistance issue, which it normally is with C. diff, because during COVID, we changed the way we prescribed antibiotics, particularly the cephalosporins, and that might have had an impact. But because otherwise, other than that, the hand washing, everything else has been very rigorous. So we're just looking into the antibiotic prescribing, Claire.
Great, thank you.
And Claire, your next question. I don't know how many you've got. How many have you got?
Just the one more, please. It was about the clinical harm reviews. When I read the paragraph in the executive summary, I know we've spoken about this a number of times, and it really is important in the current context. But I sort of felt slightly less assured than I did the last time we discussed it, just because we seem to have a large backlog, which is understandable, but it's about us knowing, what the circumstances are for those people that are waiting.
So that's me again. I'll start to answer that, Claire. Thank you. So this is very difficult. When the numbers go from tens to hundreds to thousands, it is impossible for an already stretched clinical and administrative team to look into the detail of every single of those 1,000 patients. So nationally, it was recommended that we do clinical prioritization. So patients were prioritized into those categories as P1, P2, P3, P4. P1 being emergency, P2 being urgent, P3 being within 3 months, P4 being after 3 months. So once that was done, we knew that the records of patients that were classified as P3 and P4 were looked into by clinical teams, which led to the prioritization. So in this most recent wave of the pandemic in the last 3 months, as Bruno and Sarah have said, we are not doing P3 and P4s anymore. And what we are now doing, which is actually beyond what's written in the slide, because it literally changes, every week, Claire. So what we are currently doing is Peyton, Director of Patient Safety, on my behalf, is asking the divisional medical directors to report to him about any P2 category patients that are cancelled. And if they're cancelled, then the divisional medical directors provide assurance that their records are being looked into, and those patients are either, if they become P1, if you can imagine, if someone's waiting is in a P2 category, which means they should be done within, let's say, 4 to 6 weeks. If they haven't been done in 4 to 6 weeks, do they then become P1, or can they still remain P2? And that's the analysis that the divisional medical directors are providing by way of as assurance to us. So that's happening almost on a weekly and regular basis. We also know that the patients that are at risk in P2 categories are the cardiac patients and the cancer patients, because those are the patients who are likely to need ICU beds. And if they're cancelled either because the patients got COVID in the community before coming in, or they're cancelled because there isn't an ICU bed. or the surgical or anesthetic team can't accommodate. Those are the three main reasons. And we're trying to tackle those. As you know, that patients are isolated, patients are, have a swab before coming in. However, with increasing prevalence in the community, I've even asked the National Medical Director about whether these patients should be vaccinated whilst they are prepared for surgery. However, at the moment, there isn't that guidance for clear reasons. So we try to just get as many cases done as possible in the P2 and P1 categories, and when they don't happen, we make sure that they're assessed with regard to harm on a every basis.
Thank you, Megan. I feel much more assured by that. And I just wonder whether perhaps we could change for next time just the sort of commentary on that, because I think it would help us to feel as a board much more assured. Thank you.
Yes, and I think, the whole table needs to be removed because the numbers, unfortunately, it doesn't make sense to report the numbers as they are. I'll do that.
Thank you very much. I think we need to be alert to the difference between changes which are temporary, so that we're, if you like, suspending the way we do it or adding some commentary that reflects the particular challenges of COVID, but we don't want to lose sight of the underlying timeline. But in due course, we need to come back and be able to tell what was a COVID-induced blip or what might be something that requires a more sustainable response. So I think we'd welcome executives sort of flagging for us when things need to be understood differently because of the COVID impact, and when things to reflect a similar sort of challenge that we've been monitoring over a longer period. Tony, I don't have anybody in the queue at the moment after Tony, so anybody who wants to join after Tony has a chance to think about doing that. I'm not anxious about that because I think we've dug into lots of aspects, and short of this meeting, the more time the executives have to do other things. So I'm not anxious about that at all, but I'm just drawing attention that there is a space if anyone wants it. Tony.
Thank you, Jonathan. My first question actually related to the waiting list review, but I think Megan has answered that very comprehensively. So I'll move on to a topic which is related to it in a way, and that is the current impact on ITU on our trauma services, and in particular neurosurgery, and whether that has been a problem. And I understand that we're working within the network of the East and their ITU usage, but I wonder what part we're playing in that and whether that's been a problem. And also on the transplant services, and whether they've been significantly impacted, not just by COVID in hospital, but obviously by ITU availability. The next point, and maybe I'll let Megan answer that first, is related to staffing and midwifery. So maybe Sarah would cover that.
Okay, so
with us now, so you can also bring her in as appropriate. Welcome, Sam.
Thank you. I'll start to answer. I'm sure Sarah will join to answer about the MTC neuro and transplant issue. So we, as you know, we have a neuro intensive care unit, which is separate to the adult intensive care unit, and it accommodates all patients who have either neuro related major trauma or neuro tumors or subarachnoid bleeds, aneurysms, and they have a bed base which is full. And that's because we are a tertiary referral center, as you say, so we have our own patients. Again, they are all emergency and urgent, P1 and P2, but we also take patients from other parts of the region who are neuro emergencies. What we have been able to do is, although we have stopped West Wing theatres, 7 West Wing theatres, we do have 7 theatres which are functioning, and we are able to accommodate those neuro patients and children's activity in that. So the impact on neuro is not as much as we would have perceived, but it will start to impact if we need to spread into the West Wing with COVID related numbers. At the moment, we already have spread out of neuro ITU into the recovery area, which we are complying with intensive care standards, and 5 patients are being looked after in the West Wing recovery area in theatres, in addition to the bed-based in neuro ITU. And it's a daily issue about making sure that the patients who need to be repatriated or can be repatriated are repatriated. There's dialogue between our team and the other hospital teams, also about patients who can be stepped down from intensive care or stepped down appropriately. So that's about neuro. In terms of organ transplant, we reduced the program to only facilitate kidney transplant, and actually we've done huge numbers of kidney transplant patients over the year despite the pandemic. I think we're one of the top in the country, and I mean, I saw the email recently in terms of numbers. We have actually done almost as many kidney transplants as we did in the non-COVID year. Which is extraordinary. We also have a partnership called CoxNet, which is Oxford and Coventry partnership for renal transplant. So we take patients from Coventry, and our surgeons go to Coventry over the weekend sometimes to facilitate kidney transplant. But we are not doing, we've suspended the small bowel transplant program for the moment. So Sarah, I don't know if there's anything else to add.
I think actually it'd be appropriate to bring in Sam now, because she's on the critical care network, and that might be helpful.
Sam.
I mean, we do come as a 3, but I think it's fair to say that all of our tertiary services patients are suffering from the prioritisation requirements that Megan has outlined. The very robust tertiary networks, their boundaries are extending way beyond our normal business as usual, and we've been on calls with Keith Willett and other national figures to discuss potential options there. But just as an example, today we're expecting a patient from the South Coast into our cardiac services. So the vascular, cardiac and neuro networks are working together across the whole of the southeast of England. And as another example, the risk to one of the London MTCs is really significant today. And the teams are thinking ahead at any potential risks for us to continue to operate as an MTC. So very live daily, more than once a day, discussions between triumvirates from organisations, regional and national teams.
If I could just come in there, Jonathan. So again, with Steve Powis, I did raise the issue of whether tertiary units need to be doing all 3 networks at the same time. So for us, we are doing cardiac, neuro and MTC at least, and in addition to cancer, but cancer is at a separate site. But if you look at the JR site as a whole, we have got cardiac, neuro and MTC, and a conversation with other tertiary providers, whether a reorganization of the specialized networks in the interim is possible is something I asked him, and he did say that James Palmer, who's the National Director for Specialized Services, will be looking into it, and Steve has asked for that, and he will let us know as Shelford CMOs as soon as possible.
Thanks, Megan, and Sam and Sarah. I mean, these things move incredibly fast, so I think it's important that our executive colleagues know that they have rapid access if they want to sound anything out to the non-execs, and we've done that over the last few weeks on occasional items. But we need to remind ourselves, as I said earlier, that we're in the National Incident Command and Control process, so we need to be able to free our execs to play their full role in that, and they need to understand the board covers them in doing that. Thank you. Tony, did you have another question?
Yeah, just one reflection. Actually, I think the work on the renal transplant is really incredibly impressive, and I think it would be very appropriate to pass our congratulations back to the team on being able to achieve that in very difficult circumstances. The next item actually related to midwifery and staffing, and whether the impact of COVID, reallocation of nursing, etc., has posed a challenge to maintaining safe midwifery levels.
My wife would say reallocation of midwives, as opposed to nursing. So the minute will record my protecting myself against my wife's criticisms for changing the professions. But Sam, I think we're going to respond to that.
So you'll see in the IPR our current recruitment levels of midwives, and we're in a very, very healthy position. That said, they're not without the same issues as the rest of the workforce with absence, etc. The midwives have been very active in the vaccination centre, but we haven't redeployed them currently across to any of the other pressures. The paediatric nurses are very, and docs are actually supporting the critical care pathway at the moment, but we haven't required to redeploy midwives in any way.
Thanks. Tony, any other questions for the IPR?
No, thank you.
Thank you. Megna's hand is still raised, but I think that was in responding to the point that Tony raised. Is that right, Megna? Yeah, thank you. I think then we have taken the integrated performance report. I'm very grateful to colleagues picking up the questions so we don't require our executives to present it. It's a much better use of our time, and I think enables us to dig into many more points that come out of the IPR than we've ever been able to do when we've required a summary of it before we go into it. So I'm very pleased on that. I'm also delighted that we now have Sam with us. So if we can go back to item 6 on the agenda, which is the patient perspective. And Sam, I said earlier on when we were just picking up the COVID response, we've discouraged discussions of vaccine issues because we thought it would be appropriate to have a patient perspective. And then if there are broader questions that colleagues have over the vaccine programme, we'll pick that up on the back of this. So over to you.
Great stuff. Just a couple of points to raise, really. And this is a subject, as I'm sure you imagine, dominates the whole of the executive as well as critical care. So I think the areas really to note are just an absolutely significant effort, the real one team approach. All of the executives without exception are involved in this programme. David's the SRO. Also significant support from colleagues across the states, operations, digital, clinical colleagues. There's been a really great feeling around this. It's really balanced off some of the real challenges that we've got operationally. In addition to that, another theme, and I heard Sarah mentioning this as I came in, great working across Bob. We've had support from the Chief Executive of the District Council, who's supported us with ensuring that we are able to enable colleagues from across health and social care with colleagues across Bob and indeed patients to be vaccinated. Since writing this, we've obviously got guidance around the second dose that we'll pick up later, and we've obviously got the AstraZeneca Oxford. So in terms of the patient experience, I think it's really clear, and this just grabs the experience of 5 people, and bearing in mind this went from a standing start of a service that didn't exist to seeing well in excess of 1,000 people a week. All of the individuals that have their vaccine have got a personal story, as do our staff who are involved in this. And it's just been a great team effort, I think, to ensure that we maximise capacity for patients and colleagues across Bob to be able to access this vaccine. It's clear from this paper the impact it has on people, both personally and professionally.
Thank you very much, Sam. I think you can just see that in the media coverage, you know, the sort of relief that people feel. There's a slight worry I have around expectations, including our expectations as a board on this, you know, and I keep having to remind my own parents who've now had their vaccine that this doesn't kick in immediately, you know, and there's something around us getting us a sense of perspective. This is very, very exciting, but also it runs some risks of us misunderstanding where we've got to. And the particular thing that I think, which is not our patient experience, but it is about expectations across our catchment area, which is just understanding what the next steps look like. And I'm very keen that we're clear what is our role in the next phase and how that's different from what it's been in the initial phase. Because clearly the hospital hubs have been the first point at which both the Pfizer and the Oxford AstraZeneca vaccine have been rolled out. But going forward, the community vaccination won't be our responsibility. So I wonder if you could say a little bit about how the next phases work, what we're picking up in terms of our staff vaccination programme and our own patients, and how that is integrated with the broader community response, which is being led outside the trust by Oxford Health and our local government partners.
As you say, this goes back to the right communication so that the expectations are set. And we were one of the first 50 hospital hubs This is another moving, rapidly moving landscape. Since we set up our hospital hub, there were further 2 hospital hubs set up in the BOB network, in addition to the primary care networks, and plans for a mass vaccine centre within our ICS coming online within, I think it's the next 2 weeks. So it's really critical, I think, that as a system we communicate. Lots of influx of queries coming through, and that may be picked up in Healthwatch and governors later, but very keen to ensure a system communication piece so that people know when to expect, and we follow the government communications, which is the kind of we'll call you, don't worry, we've got this, and we'll call you in terms of prioritisation, national prioritisation set, and capacity building every single day.
Thank you very much, Sam. Are there any questions for Sam or observations on the patient story or the vaccination programme? We should, on the vaccination programme, say that no, it's not just Sam. No, Meghna also got on telly, and David has been integral to this, and it is a whole team effort, but it is a fantastic step forward in terms of the response. But it won't take the pressure off our colleagues dealing with patients for some weeks yet. So we need to get a sense of perspective about having to fight this virus on a number of fronts, including all of us taking responsibility for our ability to reduce the spread along with our colleagues in the public. Sarah.
Thank you, Jonathan. I just wondered how the vaccination programme for our staff, and when do you think that we might start to see that helping with staff availability at work? So that one of the key pressures is obviously staff absence. If that vaccination programme, should we start to see that pressure on staff absence coming down as the vaccination programme kicks in? Or is that wishful thinking?
So we're working very, very closely with occupational health. There isn't national guidance out yet. So occupational health are focusing very much on the highly clinically vulnerable to review their risk assessments. Terry might wish to come in here because our people officers have got a critical national role in this piece. Terry leads the occupational health department, but we're working in close partnership with them. They've been, for a very small team, extremely active, personally contacting every single member of our clinically vulnerable staff, of which there are 120, to ensure they had the first opportunity to receive the vaccine, and are very closely working with these individuals to offer at the earliest opportunity a re-risk assessment to reduce their risk and hopefully get them back into some semblance of their roles. For many of them, it's had such an impact on them. So we're waiting for some more national guidance, and occupational health are very much part of the team in advising us how we progress.
And that's great on the very clinically vulnerable ones. But if we've vaccinated 5,000, does that help the numbers that are then off sick from self-isolation or from having COVID?
It's just, we are involved in some early pilots, infection prevention and control teams, but there's nothing national yet that says at this point that will release X back. So there's a lot of work going on to look at how we can maximise opportunity for people to be in the workplace, particularly if they're frontline.
So I've got Meghna put her hand up. Terry's shaking his head, and I'm not quite sure how to interpret that. So I'm going to find out in a moment. Meghna first, then Terry, and then I have Jason's hand as well.
Thank you, Jonathan. So, Sarah, I think the current advice nationally is that for the group of high risk or very high risk or clinically extremely vulnerable staff who've had their vaccine, they need to wait 3 months. Now that guidance may change, and we will act accordingly if it does. One of the trial that's mentioned is something we are discussing. Katie Jeffrey is discussing that, and I believe that is based on the use of tests such as the lateral flow test, but there is nothing definite yet.
So I think that's a question we might want to take away and think, how do we begin to think about the possible potential impact on that? Terry, did you want to add anything to that?
No, Meghna has covered the point. I was going to say we won't see it for 3 months. Currently we've got about 600 staff that are off altogether, along with COVID-related absences. So we'll be really keen for it to kick in, but it will be a while until we'll be in a position to see that.
Thank you, Jason.
My hand was up just in case a colleague didn't say this. Sarah, on the second half of your question, and colleagues jump in if I get this wrong, I think it's also the case that the national guidance is that even if you've been vaccinated, if you're a contact and are contacted via test and trace, you still have to self-isolate. So vaccination won't reduce the number of people necessarily that immediately who are self-isolating because they're a contact of someone who's infected.
That's correct.
Thank you. And there's a lot we don't know about the impact of the vaccine on transmission as yet. So the picture will become clearer, but we can't expect a rapid impact of that, I think, is what I'm hearing. OK, thank you. Given the actually, no, I think I'll stick with the agenda for order for the moment, because I hope I can deal with the next one, which would be scheduled. We were going to have a break, but I want to go on a little bit longer and see if we can tie up things. The proposed changes to the Constitution, item 9, is expected and hoped to be quite a short item. It's a mirror paper to one that's going to the governors, and it relates to the first phase of changes that have come out of our review of the Constitution, on which Susan Paluca has driven things forward. And these are things that relate to governor elections, which we want to have this year. I'm hoping this has been flagged and circulated, and no one has alerted me to the fact that they think this is controversial. So I'm rather hoping that that means that the board is happy to approve these recommended amendments. So I'm not going to invite Eileen or Susan to talk to it unless there are concerns. Are we happy to approve this on the basis of the paper and the work that it's in? OK, thank you very much. I'd like to move to the maternity items, and this will have the advantage that if Sam gets called away to another call, we've done her bits on the public agenda at this stage. Sam, I'll hand over to you. I'd just like to remind everybody that although we're taking 2 items here, the Ockenden report and the incentive scheme that come from frameworks for thinking about maternity that are external to the trust. The board colleagues will remember that we had our own seminar looking at maternity issues last year, so that we were able to take stock of the agenda that is driven from within, and that combines, I think, with these items that we're picking up here, and hopefully enables us to drive forward improvements in the quality of maternity services. Sam, do you want to introduce item 10?
Thank you very much, Chairman. In keeping with everything else that we're doing, whilst I'm the nominated maternity board safety champion, there isn't an executive on the team who isn't involved in this piece of work also. So the Ockenden report relates to a national review into maternity services at Shrewsbury and Telford Hospital. This report, I'll just get my notes back. This report came out in December with a number of deadlines for us to meet as an organisation, as a board. It published 12 immediate safety actions, and we've declared compliance against these, and that's in the reading room. There are 2 areas that we declared partial compliance. One relates to the ability for systematic audit through the IT system that David may wish to comment on, and the other relates to probably what I'd call maybe the clarity on the wording in relation to some of the funding and the funding streams from the maternity incentive scheme, which many organisations have replied back in terms of partial compliance. And again, Jason may wish to come in here. So requirements for us were to make that return with our response to the 12 immediate safety actions. As I say, that's in the reading room. And we're currently in the process of undergoing a very significant review into the assurance tool that came with this document. The deadline for that has been extended to the 15th of February for submission to the regional teams, and then for consideration at a future public board. So I think, as the chairman says, we have significant time spent on maternity matters, lots of discussion on all of the elements in relation to the maternity incentive scheme, and we had ourselves a whole afternoon and board seminar with colleagues, with the head of midwifery and the clinical director for maternity services. So I feel that the board are assured of our current position. Happy to bring in other colleagues, but probably best that we have the wider conversation when we've completed that assurance documentation, and we bring that for future discussion at a board once we've submitted that on the 15th.
Thank you very much, Sam. I was very keen that we had this on the public agenda because we already had it on our agenda, and demonstrating that for those who've read the Ockenden report, it's pretty sobering how long things went on in that trust without engagement with the quality issues. And I'm very confident from the seminar we had before Christmas that we're not running that sort of risk, but we do need to go through the assessment process and make sure that we're confident we haven't overlooked anything. One of the recommendations in the maternity services report is that we should have a non-exec lead on this, and I've asked Tony, because I think this is a sort of clinical issue, to have a look at that, but without prejudice to he may look at it and say actually it might be better to be somebody else when we've had a close look. But it is important that we're able to connect this with the both the executive and the non-executive leadership. Are we happy to receive and note that report and preserve our fuller discussion when we've done the assessment and we're able to pull that extra information together? Thank you very much. Sam, then we have the maternity incentive scheme.
Thank you, Chair. So the deadline for our board declaration of compliance with the 10 standards to reach the NHSR was extended in light of the pandemic from May to July, and the revised guidance we're just still awaiting. That should come in the coming weeks. There are two safety actions that are for highlighting to the board today. One is safety action 3 that relates to ability to provide transitional care, and the second relates to an effective system of clinical workforce planning, particularly around the neonatal workforce. There's a business case in preparation. There is a national shortage of neonatal nurses, and there's a full descriptor around some of the actions that we're taking in response to that. In addition to the neonatal nursing workforce, we're compliant with the neonatal medical workforce, but in the longer term there poses a risk, and that's well detailed in the document. So all of the evidence, I think, just to give the board some assurance, the evidence referred to in the table has been fully reviewed by Eileen's team, and Eileen, we wish to come in here. There's also some fairly significant information in the reading room. Currently, the service is managing to continue to work towards the achievement of the remaining elements of the scheme. And this is quite dependent on the abilities to safely staff the service, as with all services in the trust at the moment. But as Tony questioned earlier, there hasn't been any need for us to draw down on colleagues from women's services at this time, so there's no current risk to flag.
Anne.
Okay, it's come off mute. Yeah, it was just a point, maybe I've missed it somewhere, but in on page 5, when we're talking about safety actions 3 and 4, we talk about financial implications of doing this, but I can't see anywhere what the financial implications are and whether they're likely to be affordable or not. So I just wanted to get a sense of what those financial implications might be.
So they predominantly relate to the business cases and that are in progress. Workforce business case to comply with the British Association Neonatal Nursing Standards. So in progress, Jason's team are part of that business case development. Not completely sure where that is in business planning. Jason or Sarah might be able to give more information as to whether things have come through yet or not.
Jason?
Sorry, Chair, just trying to get off mute for a moment. So on that specific point, I think we've seen something on the EPR piece. I think none of the rest of it has reached the business planning group. Sam, I don't know if you've spotted this or not, but I've put time in your diary, my diary, Ali Cuthbertson and Catherine Greenwood's diary, and the Suwon Finance Lead's diary later in the month, just to do a stock take on all the requests coming out of both the maternity incentive scheme and the Ockenden report, so we can just check we're in the right place. I mean, my view, which I said to Ali, is essentially we shouldn't put a constraint on the costs of delivering safe care. So we'll work out what it costs to comply. And Ali and I've talked over the time she's been with us several times on this. I always put down a marker that when the service asks for a lot of extra money, I will do at least a brief exercise to check there's not sort of waste elsewhere in that service that can partially meet the excess. And if there is a significant safety-driven increase in costs, then all colleagues need to understand that reduces our spend for the more discretionary items. But I've told Ali that I won't put any constraint on what it costs to deliver both the MIS or Ockenden.
And you're shrugging slightly. Do you
well, I
a marker down for the next phase of discussion, or do you want to say more now?
It's only just a comment. I mean, that's an amazing response from the CFO. So, I mean, I assume that within that, and obviously that's it's a reassuring response. I'm assuming within that we don't feel that the financial implications of this are excessive, and therefore they can be accommodated in terms of our overall budgets and so on.
No, so there's a proviso. I mean, there's two things the board can do if the costs are very significant. I mean, I personally would never advise the board to not meet those quality-driven requirements. So the two other options open to a board, three other options in that scenario are: firstly, to ask for more cash from the system, which you can always ask for, but you don't often get. The second is to curtail other more discretionary expenditure to make sure that the safety-driven essential costs are met. And the third is to accept not missing your financial targets. So my preference as the CFO is if you can't get extra income, is in that second bucket of curtailing other discretionary expenditure to make sure that you fund the quality requirements. But ultimately, the trade-off between that or having a worse financial outcome is a board decision.
Yeah, and obviously there's an issue around the risk appetite, where our appetite for risk in terms of patient safety is extremely limited or low. I can't remember the exact.
I mean, I'm not freelancing exactly. When I give that view to Ali, I'm leading off the board's agreed risk appetite, that we have a really low risk appetite in this particular area, and what logically flows from that is that you meet the costs of quality requirements in one of those 2 or 3 ways that I outlined.
Indeed, thank you very much for that clarification.
Thanks. And I think my general anxiety around these maternity incentive scheme items that we bring, and the reason why we had the board seminar last year, is we tend to get a sightline on a small bit of the problem, and actually as a board we need to understand the whole nature of the delivery challenges, which is why we've done our best to bring these things together as opposed to picking them off as bits. Sam, you wanted to come in on this.
Just 2 quick points. I think one of the reasons that the midwifery workforce is in the strong position it is Jason adopted that approach with us when the Birth Rate Plus review was undertaken, in that we had this round table where we reviewed and progressed at risk, if you like, in preparation of the business case to progress the recruitment. With the neonatal team, it's slightly different because there is a national shortage and a supply issue, so we need a bit more thinking through how we might get through that. Only other point I wanted to note for the board is that we plan a neonatal seminar. I think it's in February, Neil will remind me, but we were going to do that as a joint midwifery and neonatal seminar. We're going to do a standalone neonatal board seminar in a couple of weeks' time, so that the board are well sighted on that service as well, because that's integral to the areas that we're discussing now.
Thanks very much. I think just before we leave those 2 items, I'd just like to get on the record my understanding that although we will look at the detailed assessment when it's been done, we should remind ourselves that we have regularly looked at the outcomes for mothers and babies, and that we had a specific look at a range of issues, including a lot of material on the experience of women using our services at the seminar we had. So although we won't take this as a full discussion item until we've done the assessment of compliance, we do have assurance that we have looked at indicators that we would expect to flag up problems if we had them in the way that are exposed in the Ockenden report. So this is not being deferred because we don't know. It's being deferred because we haven't completed the assessment, and I think the board can take confidence from the scrutiny it's already given that we are looking after the interests of babies and women in our care. And I think that's a fair summary of where we've got to at this stage, and I can see Megan and Sam nodding, so I think we should be clear about that on our record. Thank you. Now, my chair's brief says that I should give you a break for 10 minutes at 10:25, which is roughly what it is now, but my request to you, I think, is if we were to go on about 10 minutes now, we wouldn't need to come back after a break, and that we should complete the agenda and allow the rest of the morning to be cleared. Would that be acceptable to colleagues? Thank you. So we now have under item 12 a group of the regular reporting items which we bring to the board formally for information, but that's partly because they're usually things the board has seen in other capacities going through. The first of those is the integrated improvement plan, which in my set of papers you have 2 copies of. I've realised that you haven't got the Integrated Assurance Committee in the version that I've got. And for each of these I want to go through and take questions, please, although I will say something to the IAC paper that you may all have, but in my pack I've got 2 copies of the update on the Integrated Improvement Plan. And I have Paula's hand has been raised. Paula.
Okay, thank you. Yes, I focused on the theatre page actually, which is page 189 of the whole pack, because one of the things that we've put a lot of effort into, or we were putting a lot of effort into pre the pandemic, was our theatre improvement programme, and there's a lot more information here. But looking at the cases delivered going up, the sessions delivered going up, and again, these are November data, so it has the same point that life will have changed, I'm really sure. But then moving on and seeing that actually on the efficiency, we're not managing to achieve increased efficiency or increased utilisation, really. I got to the end of this page and thought, I'm not sure what I should really take out of this. And in any event, I'm sure this has got very overtaken by events. I'd welcome an update. I thought Megan might just be able to tell me what I should take out of this a bit.
Yeah, thank you, Paula. So you're absolutely right. We have progressive improvement in numbers of cases and numbers of sessions completed from August until December, such that the numbers matched the performance of December 19, which was also when we were on a high trajectory, which was fantastic. And then again, rather dishearteningly, it has come to a crashing halt because of the reduction in theatre activity. With regard to the efficiency is calculated on the basis of number of cases scheduled that are completed in a given time that is allocated without any cancellations, underrunning or overrunning. Now, we have, as you can see in the adjacent chart next to efficiency, the underruns and overruns, and that along with the on-the-day cancellations, which we suffered as a result of all the COVID pre-testing and the rest of it related to COVID, meant that the efficiency wasn't as high as we would like it to be, although this is showing you the average efficiency. And I know that in certain other specific theatre areas, the efficiency and utilisation both increased. So the NOC increased their utilisation remarkably in the months of November and December, as did the West Wing. One of the things highlighted here is the West Wing provision of the emergency list. So we did not have an emergency list in the West Wing, particularly for neuro, which meant that on a regular basis, neuro emergencies were eating into elective lists, thereby leading to cancellation of neuro activity and children's activity. So you'll see that in November 2019, 23 adult cancellations and 6 pediatric cancellations happened due to the emergency list. By creating an additional emergency list in that theatre, what it showed was we used 106% of the capacity made available for emergencies in the West Wing Theatre in that theatre, such that only 2 elective cases by comparison needed to be cancelled that month. which is actually just shows how reorganization after the West Wing theatres were remodeled has created that efficiency and change. Again, similarly, you can see in the graph the increase in the trauma and orthopedic activity. And all the 4 clinical directors listed there are very engaged in this program and have been doing superbly well. And we have drilled down in the Churchill, we've drilled down into urology, and there's a urology improvement plan again. But as I say, it's a bit sad that it's all come to sort of a same thing again, which means I'm now keeping teams engaged and motivated to say we got to get going again and show that again the steep recovery that we've achieved, because now we know how to do it. So let's just keep engaged with this activity. So what you need to take away from this is our teams are ready and geared. The shortfall in theatre staff that we had was recovered, as a result of which we could do more and more cases and more sessions were open. However, we do have a challenge because of the organisation of the COVID-related issues in the underrunning and overrunning, which is nobody's fault. It just seems to happen that sometimes patients don't come in, or they come in and they wait for a test result and the test result is not available. And if a large case goes down, that shows up as a big underrun. So I think the key message is we are on to this. Everybody was working hard. We now need to go back to make sure that the staff that we recruited are there, and if they're not there, back to square one to try and employ the long lines, etc., required to get our staffing back online to go full pelt at this.
Okay, thank you. That's really helpful, because I know just how much effort you put into getting the processes right to make the improvements in this area. So actually, that's really helpful. Thank you, Meghana.
Thank you, Meghana. Are there any other questions on the integrated improvement plan? Learning from deaths. Any questions on the learning from deaths Q2 report? Meghana, anything you want to say about that?
Yes, thank you, Jonathan. 2 things. One is I'm sorry that 11% of the deaths didn't have a review within the 8 weeks as stipulated. I mean, teams are working exceedingly hard, and this is all mainly sits within MRC division, who have the bulk of the work in terms of inpatients during COVID. So they will catch up as soon as possible, and we will make sure they're reviewed. That's the first thing. And the second thing to add is, of course, that SHME and HSMR are below 100 or below 1, which means we are within expected and below expected for HSMR. And the last thing to say is that all our medical examiners are now in post, and they're all reviewing all COVID-related deaths, as is the ask from the National Medical Examiner from them, and they will meet that by the 1st of April. And once they release their report to the National Medical Examiner, of course, we will also get it. So I will bring it to board when ready.
Thanks, Meghana. And I note from the paper that so far as we can rely on these indications, which I think is too early to put too much weight on, our COVID mortality is the right side of the average, and we know that we did very well in intensive care last time round. But that's good to see. But we shouldn't put too much weight on that until the full analysis is done.
Exactly. Thank you.
Thank you very much. If I then could speak briefly to the integrated assurance report. Those of you working from Diligent will have it. Everybody else, it's in your emails now. But as some may not have seen it, I'll just quickly remind everybody that Integrated Assurance Committee you were all at, because the Integrated Assurance Committee has us all, plus divisional directors on. A number of areas we discuss every time we meet. We've talked about COVID response and recovery. We reviewed the integrated performance report. We looked at also, though, the integrated care systems level of surveillance of elective care. We'd asked for there to be a common view of that all organisations shared, and we received that and talked about it at the Integrated Assurance Committee. We looked at the Q2 performance reviews and heard about the themes and issues that came out of that. We noted the new performance management and accountability framework, which I think gives us significantly more consistent assurance around the approach to performance management throughout the organisation, but particularly in the clinical and corporate divisions. We had a deep dive into issues of frailty and had presentations from clinical staff across medicine, rehabilitation and cardiac division. And we had an update on the response to the Pattison inquiry. Colleagues will remember that that is the inquiry in relation to a surgeon who worked across the independent and NHS sector, and it took a lot of time to pick up the problems that were there. And there are 8 recommendations from that we have reviewed, and there's an action plan in place to address the gaps. So I hope the board is able to take assurance from the fact that it's been over that range of things, some of which we've looked at again today in our normal business cycle. I'm happy to take any questions. Thank you very much. The TME executive report is in the papers, and I just check were there any questions for Bruno as chair of the TME out of that. Thank you. Bruno.
Yeah, I'm happy to just highlight maybe the international recruitment, which is quite relevant also for the COVID-19 response. So we've been very successful in the international recruitment, and it's been a key focus of TME to get even more funding and more effort behind this, and it's been quite successful. I see Sam raising her hand, so she can talk a bit more about that in a minute, but I thought of highlighting that effort out of the TME report. We will also have our first risk committee tomorrow. It's a new subcommittee of TME, and we'll talk about some of the risks around fire safety and cladding and issues that have been discussed at the board quite extensively. But for example, the oxygen supply is also a risk that we'll talk about tomorrow. And then finally, as you can see, we've made quite a lot of decisions to renew contracts or buy equipment. It's been a very successful year for the trust to attract capital to either refurbish, for example, our AD departments at the John Radcliffe or at the Horton, level 5 at the John Radcliffe. But also we've been able to order quite a lot of equipment as part of the successful capital bids, and you'll have an update of that in the report. Sam, you want to say a bit more about the international recruitment, maybe?
Yeah, I wasn't going to, but it's just such great news. I think we should have a bit of a light moment. So combination of people in Terry's team, Jason's team and my team have tenaciously managed to get well in excess of £1 million from the centre to support a variety of streams to support international recruitment, which is fantastic. We have 40 new nurses joined us about 5 weeks ago, and they're currently, I think Jason's team are operating as travel agents at the moment, working which air route they can get the next group of colleagues through. Our OSCE, which is the exam that the team take to get onto the NMC register, has got significant, high proportion of pass rates, and the NMC are working with nursing across the country to look at temporary registration of overseas nurses who are at certain points in process with their NMC application, which will probably yield us a further 20 registrants. But it's just great teamwork in between finance, HR and nursing workforce. So it's just been a good couple of months for us.
Thank you very much, Sam. Let's end on that high note. The remaining item is information on consultants who are joining us. So given what we've said right at the beginning about how proud we are of our workforce and our colleagues delivering this, it's great that we're getting some more to join us. I'm not aware of any other business, so I would like the board's agreement then to close the public meeting of the board. I know you didn't get a coffee break, but no, at least that releases a bit of time afterwards. Obviously, colleagues have a confidential session of the board, so if we were in a public meeting, I would pass the usual resolution to exclude the public for discussion so we can look at issues that are not permitted to be discussed in public. doesn't quite work like that, but the record will need to show something similar. And then many of us will reconvene either for virtual coffees as non-executive directors with members of the Council of Governors, and then formally for the Council of Governors meeting this afternoon. And as we said earlier, we'll have a major item there on staff wellbeing. So my contribution to the wellbeing of the executive directors is to give them a chance to have some coffee and save about 10 minutes of their lives that they would otherwise be devoted to the board meeting. Thank you very much, everybody, for being so focused. I think we've done the work that we needed to do efficiently. And with that, I suggest you refresh yourselves, and I look forward to seeing my colleagues for the confidential meeting a little bit later on. Thank you very much, everyone.